Today, assalamu alaikum, good morning guys. Today I'm going to talk to you about something called silicosis, which is a disease, one of the spectrum of restrictive lung diseases, and it's it's one of the occupational lung disorders, and it causes inflammatory restrictive lung disorder. So we're going to start with our case scenario. 42 years old man presented with worsening exertional dyspnea for 10 years. It progressed in the past 7 months and become present at rest. So progressive exertional dyspnea for 10 years, chronic, and he have non-productive cough, fatigue, otherwise normal drug and family history. He worked for 10 years as a stone cutter, and his full blood count is normal. ESR is high in the first hour. So to sum this, patient is having worsening exertional dyspnea for 10 years, progressed in the past 7 months, fatigue, worked for 10 years as stone cutter, high ESR. Continuing his medical history, the patient and examination, the patient PMI is low. You have normal examination, general examination and saturation. So he's not cyanosed, there is no clubbing fingers, there is no apparent respiratory distress, and so you have normal oxygen saturation, normal cardiovascular examination. In the chest exam, he have reduced chest expansion in the right upper zone of the chest, dull percussion in the right upper zone of the chest, and you have bronchial breathing in the right upper zone of the chest. These are the features of fibrosis. You have multiple polyphonic wheeze in both chests. So you have diffuse fibrosis, mostly present in the right upper lobe of the chest. So we have done investigations for the patients, and we started with tuberculin test, and it was negative, and then we followed this by chest x-ray. Why we did tuberculin test? Because the patient is having upper lobe fibrosis, and the patient is having shortness of breath for 10 years, and he worked as stone cutter, because if the patient is to have silicosis, TB is a risk factor, you see. So chest x-ray showed large nodular masses in both our lungs. High resolution CT showed bilateral fibrotic masses with pleural thickening in the right upper zone of the lung is more affected. Then what we do again, we will do pulmonary function test, of course. So the pulmonary function test for the patient was mixed, showed restrictive and obstructive patterns. So how do we gonna treat this patient? As the patient is negative for tuberculosis, we don't need to treat TB, and there is no treatment for silicosis. We only prevent the patient from developing influenza. So we give the patient influenza vaccine. So how did we reason this? How did we diagnose the patient as silicosis? A careful analysis of the characteristics of the dyspnea and associated symptoms is the key toward localizing the organ system and narrow the differential diagnosis. So our patient is having a progressive dyspnea. It become apparent at rest. Okay, so the patient chronic dyspnea is a common complaint in respiratory practice. You have to know that our key differential diagnosis includes cardiac etiologies such as valvular heart diseases can cause dyspnea. Other differentials: heart failure, respiratory distress, and diseases such as chronic obstructive lung disease, interstitial lung disease. So differential diagnosis for chronic dyspnea fall in these 4 categories: valvular heart diseases, heart failure, obstructive lung diseases, and interstitial lung diseases. There is no history suggestive of prior cardiac disease. The patient have no any past medical history of specific disorders, nor are easy fatigability, paroxysmal nocturnal dyspnea, and orthopnea, which are features of heart failure. So there is no dyspnea about lying flat or dyspnea at night that awaken patient from sleep, and there is no easy fatigability. So we cannot go toward the heart failure with much confidence. You see. So chronic obstructive airway disease, the other differential diagnosis, is typically characterized by a history of exacerbations and remissions. So it's going to increase and decrease. It's going to, as we said previously, so it's going to increase and decrease. It's not going to be steady problem, and the shortness of breath is not going to be progressive. It's going to be exacerbating and remitting. And you need a history of smoking. In most patients, there is history of smoking when the cause is COPD. While interstitial lung disease typically present with slow but relentlessly progressive history, while non-productive cough is often present. Thus, this is the most clinically likely scenario. Okay. So, examination further revealed a localized region of dullness in the right upper zone. Dullness, decreased breathing sounds, decreased expansion, and bronchial breathing. A very few interstitial lung diseases give rise to a localized sign. Of these, silicosis is the most prominent. So, when you find a localized respiratory sign in a patient with interstitial lung disease, you always think of silicosis. The history of work as a stone cutter further supports this analogy and makes silicosis more likely. So, when considered along with the presentation, these findings are diagnostic of silicosis. Which finding? The chest X-ray finding. So, when you consider the chest X-ray finding along with the presentation of the patient, you can diagnose silicosis, which is bilateral motile opacities and large nodular masses, which are prominent in the right upper and mid zones of the lung. A high resolution CT should be performed too. So we did a tuberculin test to exclude TB, we did chest X-ray to confirm the diagnosis, and CT scan is more sensitive in discriminating and assessing the nodules, so we do high resolution CT. Then we do lung function test, of course, to quantify the degree of respiratory impairment, sure, and the mixed pattern can present in advanced silicosis, obstructive and restrictive. And finally, we said that tuberculin test in all patients with silicosis must be performed because TB is frequently associated with silicosis because they have a decrease in the immunity function of the respiratory cells. So silicosis is incurable. The management is aimed at slowing the progression of the disease and the complications. So you immunize the patient and you supplement oxygen only when there is an indication. No, when the patient saturation is normal, you do not supplement oxygen. You only supplement oxygen when it's necessary, and given that he is not acutely dyspneic and he is not desaturated, you do not give our patient oxygen in the scenario. And the antibiotics are not indicated in our patients. You only give them when there is an indication, and steroids may benefit in patients with acute silicosis but not with chronic. Further, we're gonna talk about the types of the presentations of silicosis, and you're gonna know the difference between the acute and the chronic and the progressive massive fibrosis. Okay. So, what we know about silicosis is a disease caused by inhalation of silica dust, and is the most or one of the most important occupational lung disease. It's usually caused by exposure to silica particles, which is smaller than 10 micrometer in diameter, very small. Occur in mining, drilling, sand blasting activities. Stone cutters worker. There are three types of silicosis: chronic, accelerated, and acute. If the patient can present acutely, can have an accelerated disease and progressive disease, and can have a chronic form of the disease. The remainder of the discussion will focus on the silicosis. As our patient was presenting, so chronic silicosis is the most common form of the disease and usually develop after 10 years, okay, of the exposure to relatively low dust concentration. So low concentration, prolonged exposure give you chronic silicosis. Chronic silicosis can be further divided into simple, complicated. So we have acute, chronic, progressive. The chronic can be simple, can be complicated, also called progressive massive fibrosis. This is a complicated chronic, a distinction which can only be made via the chest X-ray. So we cannot say that the patient is having a simple chronic silicosis or progressive massive fibrosis or complicated silicosis, I mean, unless we do chest X-ray. Okay. So the pathogenesis of the condition: once the silica is inhaled, they become lodged in the distal part of the respiratory tree. What do you think we mean by the distal part of the respiratory tree? If you think respiratory bronchioles and alveolar ducts and alveoli, then you are in a good shape. So the surfaces of these particles generate silicon-based free radicals that lead to production of oxygen free radicals, which cause damage to the cell membrane. So the silica enter the respiratory, the lung, and specifically at the distal respiratory bronchioles, it become lodged here in the distal, for example, respiratory bronchioles. So when it lodges there, they generate free radicals inside the respiratory cells. So the generation of free radicals will do what? Will harm the cell membrane and will causes damage to the alveoli in the respiratory bronchioles. So when the alveoli and the respiratory bronchioles and the alveolar ducts are damaged, then what is going to happen? Inflammation and fibrosis. Laying of collagen fibers and fibrosis, and this lead to restrictive lung disease, interstitial restrictive lung disease. Alveolar macrophage gets these particles become activated, release cytokines, because it cannot kill the silica, it cannot analyze the silica, so it permanently stay in the macrophage, and it permanently causes inflammation. The ensuing event causes damage to resident cells. So this event that is happening lead to the damage of resident cells, result in fibrosis of the lung parenchyma, and patients are susceptible for TB, chronic bronchitis, mycobacterial infections, fungal infection, and emphysema and pneumothorax. So these are the complications that may occur in patients with silicosis because they are more vulnerable to the tuberculosis, chronic bronchitis, non-tuberculous mycobacterial infections, fungal, and emphysema pneumothorax. The risk of lung cancer is also increased up to 4-fold more in patients with silicosis than in general population. So if you are a general population that do not have silicosis and this is a patient with silicosis, you're gonna have your risk, but he's gonna have a 4-fold increase in the risk than you. So how do we diagnose silicosis? The diagnosis is based on the history of exposure, the chest X-ray appearance, and an absence of other diagnosis that stimulate that simulate the radiographic abnormalities of silicosis. So, exposure, chest X-ray appearance, exclusion of other diseases. Symptoms of chronic silicosis manifest as only 1 to 3 decades, so after 10 to 30 years of the initial exposure. Okay, so typical history of exposure, chronicity, appearance of symptom after 10 to 30 years of the exposure, chest X-ray appearance, exclusion of other diseases. You can find them here. It's chest X-ray appearance, absence of other diagnosis, exposure, symptoms manifest only 1 to 3 decades after initial exposure. So, individuals who develop symptoms within 10 years after the initial exposure, they may have accelerated form of the silicosis and are more likely to develop progressive massive fibrosis, which is a complicated chronic silicosis. So 10 years period for development of the symptoms after the exposure is a poor prognostic sign. So patients with silicosis or with simple silicosis may be asymptomatic or may present with exertional dyspnea and productive cough, while in progressive massive fibrosis, dyspnea and productive cough are often combined by constitutional symptoms like malaise, weight loss. So when you have a simple silicosis, you may only have exertional dyspnea, productive cough, but progressive massive fibrosis, you will have constitutional symptoms. Have to focus. This is a very tiny difference, but you only can tell with chest X-ray. Physical finding is unremarkable in simple silicosis. Tachypnea, exertional prolongation, rhonchi and wheeze may be present in complicated silicosis, while clubbing is uncommon in both of them. So in advanced cases, copulmonary may present like in sarcoidosis, like in idiopathic massive fibrosis or idiopathic fibrosis, pulmonary fibrosis. So now you know how we diagnose. The primary method of diagnosis is chest radiograph. In simple silicosis, chest X-ray usually shows small round opacities. Hilar lymphadenopathy sometimes present and calcified. Similar calcification may also be seen in sarcoidosis. You have to keep it in mind. So history of exposure, typical symptoms, beginning of symptoms after 10 to 30 years, then chest X-ray findings and exclusion of other similar diseases or diseases that have similar appearance on chest X-ray. So the primary method is chest radiograph. Chest X-ray showed small round opacities, upper zone predominance, and the hilar lymph nodes calcified, they called eggshell pattern. Also observed in other cases like sarcoidosis, radiation treated Hodgkin, scleroderma, amyloidosis, histoplasma, and blastomycosis. So this is the differential diagnosis for eggshell calcification of the hilar lymph nodes. So let's see the eggshell calcification of the hilar lymph node, and you can find it here. It looks like the egg, and it calcified here. So then we can do a high resolution CT, which is more sensitive than chest X-ray, and it's unnecessary if the chest X-ray appearance shows characteristic nodules. Rarely you need bronchoscopy in order to arrive at a diagnosis. So we do HUCT, and we may need bronchoscopy if we couldn't arrive at a diagnosis. So this is the high resolution CT. Is showing fibrosis, massive fibrosis, and opacities and large nodules in the upper field of both lungs. Right? Very nasty chest X-ray. Very nasty CT scan, I mean. So how we're going to treat these patients? we're going to treat silicosis symptomatically. There is no proven curative treatment for silicosis. The main goals of management is to improve the quality of life of the patient, you see, and to prevent the patient from deterioration. So first thing you do, you remove the patient from the exposure, avoid further exposure. If the patient is smoking, you stop smoking. If the patient is not vaccinated, you give him an influenza vaccine and pneumococcal vaccine to reduce the risks of or the possibilities of complications and contracting other infections. See? What do you think that another thing we can do? If you think only symptomatic management, you are correct. For example, if the patient is having wheeze, having airway obstruction, we can give him bronchodilator. If the patient is having fever, SIRS, systemic inflammatory response syndrome, or sepsis, we give the patient antibiotics. If the patient is having fever, we give the patient antibiotics, and so we treat the patient symptomatically. So if there is a need for bronchodilators, we give the patient bronchodilators and cough suppressant. If there is a need for antibiotic, we give the patient an antibiotic. If the patient is having silicosis and diagnosed, there is no evidence that corticosteroid confer long-term benefits. So if the patient have accelerated silicosis, such treatments like steroids can increase the risk of the patient to have tuberculosis. So actually you avoid steroids in patients with silicosis. While if there is an advanced disease without other comorbid conditions, lung transplantation may be option. So if the patient is having progressive massive fibrosis and he have normal body health in general, we transplant a lung for the patient. So sometimes patient may have silicosis and we trying to exclude TB. We found that the patient is latent for tuberculosis. What we're going to do, we treat the patient as a latent case. We give the patient, so latent tuberculosis means that positive tuberculin test with a chest X-ray finding. So we give the patient isoniazid for 9 months, and the pathological feature of silicosis continue. The pathological feature of silicosis will progress and may result eventually in respiratory failure and death. So the way the patient present, we can use the presentation of the patient to predict the prognosis of the patient. But the progression of the disease must be considered in a case-by-case basis, depending on the time of the exposure, the length of the exposure, the amount of the exposure, and the symptoms of the patients. So what we have learned from this topic is that chronic silicosis is the most common form of silicosis. It's usually developed after 10 years of exposure to a relatively low dust concentration. No treatment. The goal is to improve quality of life and prevent deterioration. Lung transplantation is the last resort. And this is how we're going to conclude this topic. Easy and fine. Bye bye.